Good morning. This morning I am discussing Apogeotropic Posterior Canal BPPV, the plus variants, that is something other than just Apogeotropic Posterior Canal BPPV. So the red one is the short arm of the posterior semicircular canal of the left side. The green one is the long ampullary arm of the posterior semicircular canal, and this is in pink is the non-ampullary arm. An otoconal debris that dislodges from the uticular macula and gets embedded. Just see that I am using the word embedded for a particular reason that you will know over few slides. In the non-ampullary arm results in the peripheral positional downbeat nystagmus, which is now the most common cause of positional nystagmus, which is downbeating and peripheral in origin. The third provoking question is that why, how otoconal clot remains stable in this strategic location, that is the non-ampullary arm near the crus commune. This is the left membranous labyrinth of this gentleman, and in red you see the otoconal debris in the non-ampullary arm near the crus commune. As the patient lies down, it is expected to fall backward and thus transform to typical posterior semicircular canal BPPV, but it doesn't happen so. Likewise, if the patient bends forward or lies prone, the otoconal debris is expected to fall into the utricular macula and get embedded, leading to autocorrection. But these two things seldom occur. Probably a partial canal jam is almost always present, which may be due to a narrow semicircular duct or a large otoconal clot or both. So BPPV subtypes in the various studies, mostly at the tertiary dedicated vertigo clinics. It is important to note that in 2021, Califano showed that Apogeotropic Posterior Semicircular Canal BPPV is around 6 times more common than the anterior semicircular canal BPPV. So now the commonest cause of peripheral positional downbeat nystagmus is Apogeotropic Posterior Canal BPPV and not anterior semicircular canal BPPV. A study of 2007 by Jackson shows that 21.2% of the cases in a series had anterior canal BPPV, but the apogeotropic variant of the posterior canal BPPV was not known at the time. So probably many of these cases included the apogeotropic posterior canal BPPV now, which is a well-defined clinical entity. So the excitatory projections of the left anterior semicircular canal, that is the ampulofugal cupular deflection, and the inhibitory projections of the right posterior semicircular canal are to the same pair of muscles, and they co-contract as per the Sherrington's and Herring's law and generating a slow phase VOR, which is upbeating and right torsional. The peripheral positional nystagmus, which is a fast phase VOR or a reflexive saccade, is therefore downbeating and left torsional, whether it is left anterior semicircular canal BPPV or an apogeotropic posterior canal BPPV. Because apogeotropic posterior semicircular canal BPPV is 6 times more common than anterior canal BPPV, I therefore treat peripheral positional downbeat nystagmus as apogeotropic posterior semicircular canal BPPV more often than anterior semicircular canal BPPV. So with this I start my first case. This is a 5th April case, 33-year-old female with 10 days history of positionally triggered disease spells on getting up from supine in both lateral recumbent positions, multiple vomitings and a severe non-positional disequilibrium requiring support of one person to stand and walk. The extraocular movements and the head impulse test showed no abnormalities to the either side. The left Dix-Salpike test elicits a slow crescendo decrescendo downbeat nystagmus with a left torsional component. So this nystagmus is generated by the otoconal debris in the right-sided non-ampullary posterior semicircular canalolithiasis. This was a pretty long nystagmus of 1 minute duration. I have scrolled it to almost 1 minute. So now on the Dix-Hallpike test on the right side, this also elicits a slow crescendo decrescendo downbeat nystagmus, but the torsional component has now reversed. It is right torsional now, and this can be attributed to the canalolithiasis in the non-ampullary arm of the left posterior semicircular canal. So how we treated this patient is outlined here. We treated with the quick liberatory rotation maneuver, which were first used by Califano, 5 QLRMs for each side for 2 sessions per day for 3 days. She did not respond. From day 4 to day 28, Brender of exercises, followed by 45-degree forced prolonged positioning for an hour, alternately left on one day and right on the next day. At the end of 4 weeks, that is 30 days, the patient was re-examined again. No positional nystagmus is elicited in the left Dix-Hallpike test, which was maintained for around 1 minute. And there was no nystagmus elicited on right Dix-Hallpike test as well. This patient underwent a MRI brain and CVJ screen MRI, and which was normal. So the diagnosis is bilateral apogeotropic posterior semicircular canal BPPV, possibly with partial canal jam, and the inertial forces used during the Brender of exercises probably helped in clearing the jam. So the second case is a 38-year-old male with history of assault a day ago, presented with positionally triggered dizzy spells, vomiting and non-positional disequilibrium. Right Dix-Hallpike test shows upbeating right torsional crescendo decrescendo positional nystagmus of less than a minute duration, suggestive of long ampullary arm right posterior semicircular canalolithiasis. That is the typical variant. The left Dix-Hallpike test shows direction reversing positional nystagmus as under. There are 2 nystagmi. The first nystagmus is upbeating left torsional crescendo decrescendo positional nystagmus of a less than 1 minute duration, suggestive of long typical ampullary arm posterior semicircular canalolithiasis of the left side. After this, a downbeat left torsional slow crescendo decrescendo positional nystagmus of more than a minute duration suggests a non-ampullary arm right posterior semicircular canalolithiasis. So the direction reversal is apparent. There are 2 distinct nystagmi. The first positional nystagmus is due to the periampullary juxtacapular left posterior semicircular canalolithiasis, and the second downbeat nystagmus is due to right-sided non-ampullary posterior semicircular canalolithiasis. So how was it looked like? Here it is. Upbeating right torsional nystagmus around 15 seconds. On left side, upbeating left torsional nystagmus, again around 15 to 20 seconds, and then there is a pause. A second nystagmus occurs, which is downbeating slow crescendo decrescendo, and the torsional component remains same, that is left torsional. So this is attributed to the right non-ambulatory arm posterior semicircular canal lithiasis. This lasted for about a minute. Scrolling it forward, so treatment of case 2, treated with right applied maneuver at first, at 1 hour later treated with left applied maneuver, at 24 hours asymptomatic with negative positional test. So how did the applied maneuver work on either side? This is the right sided applied maneuver, and there are two orthogonal debris. One is periampullary and other is non-ampullary near the cross commune. As the patient was taken to the position 2 of the applied, that is contralateral recumbent with nose down, the orthogonal debris, they attained the lowermost part of the canal in this position, and when the patient was taken to the position 3, that is lateral recumbent to the opposite side with nose down, the orthogonal debris moved towards the crus commune, and as the patient was taken up to the short sitting, there was repositioning, and both the orthogonal debris, one at the non-ampullary end and other at the periampullary region, they are repositioned back into the utricular macula. The case 2 diagnosis is bilateral typical posterior semicircular canal BPPV and right apogeotropic posterior semicircular canal BPPV. Case 3 is a female seen on 23rd March, 63-year-old with 5 days history of positional vertigo and a constant non-positional disequilibrium in the upright positions. Left distal pectus elicits upbeating left dorsal positional nystagmus of more than a minute duration. Positioning the patient from left distal pec to right lateral recumbent with nose down, that is the inversion test, results in change in the direction of nystagmus to right torsional and downbeating. That is the positive inversion test. The oculomotor patterns from getting up from the left distal pec position elicits a left torsional upbeating nystagmus, again reinforcing the direction of left posterior semicircular cupulolithiasis. Right distal pectus elicits a right torsional downbeating slow crescendo decrescendo positional nystagmus of more than a minute duration. Uprighting from the right distal pec position elicits upbeating left torsional reversal nystagmus, which is rather unusual in the apogeotropic variants of the posterior semicircular canal BPPV. This is her video. Left distal pec test. You see a upbeating left torsional nystagmus. Scrolling it to around 50 seconds, it is still present. At 1 minute and 15 seconds, it is still present. So now at 1 minute and 45 seconds, the inversion test, that is right lateral recumbent with nose down, is being carried out. The nystagmus changes direction. Vertical component, which was upbeating in the left distal pec position, becomes downbeating, and the torsional component, which was left torsional in the left distal pec position, now becomes right torsional. So this confirms left-sided posterior semicircular cupulolithiasis. It is now more clearly seen with the adjustment of the video frenzials. Getting up from the left distal pec position, upbeating left torsional nystagmus, reinforces the diagnosis of left posterior semicircular cupulolithiasis. There is no reversal nystagmus in posterior cupulolithiasis. Right dixalpine test shows a slow decrescendo, decrescendo, slow downbeat nystagmus with right torsional component. The upper pores of the eyes, the left eye is more clear, are torsionally beating towards the patient's right. So this suggests an additional canalolithiasis in the non-ampullary arm near the crus commune of the left posterior semicircular canal. On rising from the right dixalpine position, we see a upbeating left torsional nystagmus. This is the reversal nystagmus, and this is very rarely reported in patients with apogeotropic posterior semicircular canal BPPV. Treatment of this case: she was treated with Demis-Hammond maneuver for the left apogeotropic posterior semicircular canal BPPV. Next day, her oculomotor patterns only revealed the nystagmus of left posterior semicircular canal cupulolithiasis, which we tried to manage by the mastoid oscillation, but that didn't work, and we advised Brander of exercises for a month for left posterior cupulolithiasis based on the recommendations of SCOCO of 2022. So the case 3 diagnosis is left apogeotropic posterior semicircular canal BPPV and left posterior semicircular cupulolithiasis. So the summary of plus variants is: case 1, what is plus? Left apogeotropic posterior semicircular canal BPPV plus right apogeotropic posterior canal BPPV. Case 2, right apogeotropic posterior semicircular canal BPPV with bilateral typical posterior semicircular canal BPPV. Case 3, left apogeotropic posterior semicircular canal BPPV plus left posterior semicircular cupulolithiasis. So the case 1 and case 2 are in fact multi-canal BPPV, where one of the canals was the posterior canal but the non-ampullary arm near the crus commune, and the case 3 is a case of cupulocanalolithiasis. I finished my talk here. Thank you.